And now we have again a very best friend of WEO and also of Europe. He took the leadership in what is a nightmare, the incomplete resection of a polyp as possible cause of interval cancer from the Guy's School of Dartmouth, one of the most renowned place in Vermont now, Heiko. Heiko is giving a talk this time on how to optimize endoscopy resection. Thanks, Heiko, for joining.
Thank you, Rodrigo and Cesare, and thanks for the invitation to talk on this topic. Are you seeing me, or I have my video on?
Yes, we can see you very well, Heiko, as you are here in Europe.
Excellent. Nice to be back in Europe. Actually, I miss it. I'm not sure whether I can move forward here because it's still a Q&A thing, but here we go. Thank you. So, well, we heard about AI trying to improve adenoma detection. I just want to mention that resection is in the center of any screening effort. Any screening test you do, you have to perform a colonoscopy, find the lesion, and then resect it. If you do not resect it completely, you end up having a higher risk in the segments of the colon to come, more than double. And you may end up with an interval post-colonoscopy colorectal cancer. We think 10 to 28% of these are attributed to incomplete resection. Now, as we're hearing a lot about improving adenoma detection, we hear little about improving incomplete resection or completeness of resection. So I think you can approach complete resection into two ways: apply the right technique and choose the right approach. So let's just see what we can do about that. First, what does it mean, the right technique? I think it's two things. One's the right principles. And here I want to point out, any polyp resection needs to include an inspection first. Is it resectable? Is it cancer? The resection, as you can see on the right in the moment, the inspection after, and the retrieval. Now on the right, you can see the skill, which is the second part of the technique. Like with cold snare resection, you push in gently into the wall to keep a healthy margin. So I'm going to move forward and not going to skip this one. So what does it mean to apply the right approach? Well, the ESG and the societies know what the right approach is, and therefore they come up with the societal guidelines. And here you can see on the left the ESG from 2017 and the most recent from the US MSTF 2020. But what's maybe the most important change is the move from hot to cold snare resection. So the primary resection approach should be cold snare resection for all that are less than 10 millimeter. But the US societal guideline also considers to use cold snare resection for 10 to 19 millimeter polyps, which is both are fairly new and break with the tradition of using hot snare resection. Now, the other important thing is that we need to get better with image recognition, and image enhancement tools should be used for all polyps 10 millimeters or larger. And then there is the issue of clip closure for large colorectal polyps. So let's just look at this. Why is there a move from hot to cold? Well, there are numerous studies that have shown on the left-hand side that cold snare resection is safe. There is hardly any bleeding, and it's also effective. Some comparative studies with hot snare resection for those small polyps show that the efficacy is similar. How about those that are 10 millimeter to 19 millimeter or larger? So you see here on the right side of this diagram, there's hardly any significant adverse event, no perforation. And by the way, the two graphs represent the size groups, and no bleeding. Some abdominal pain and some intra-procedure bleeding that typically can be easily controlled with clips. And also, surprisingly, the recurrence rate is not that high. Actually, for those that are 10 to 19 millimeters, it's only 4%. For those that are 20 millimeters or larger, it compares to what Cesare has published with his colleagues in the meta-analysis in gut a few years ago on EMR and ESD. So now we realize that those that like you doing cold snare resection, maybe not all polyps can be resected cold, and that not just size issue, but the bulkiness. We need a measurement for bulkiness, by the way. So but it's probably good for flat polyps. So here is a recent meta-analysis that included 14 studies on serrated polyps. And the bottom line is in blue, cold snare resection, in orange, hot snare resection, and no perforation, no post-procedure bleeding, some interprocedural bleeding, and actually the significant reduction with all the complications with cold snare resection. And somewhat surprisingly to me, the recurrence rate was less than 1% in this meta-analysis compared to historical hot snare resection studies, 5%. Now, it just probably the historical study by the Doug Rex group found an 8% recurrence rate in historical patients, more than 500 polyps, but combined these all add up to about 5%. So it seems like similarly effective, but safer if you use cold snare resection for large serrated polyps. So my prediction is that this is going to become the standard of care because I think there's already sufficient evidence to make that standard of care. Now, we're running out of time. Unfortunately, this is one of my favorite topics, the clip closure of large polyps, reducing the risk of bleeding, but only in the proximal colon. This is a very nice meta-analysis by the Italians that showed that if you clip 20 mm larger polyps in the proximal colon, you reduce it by about 2/3, no effect for distal large polyps, no effect for smaller polyps. So it's important that we start thinking about how to assess completeness of resection. There are some skills assessment tools. They're not as practical just because the metrics are 12 or 33 that you got to check off. And the other thing is, what do we do in clinical practice? Now, there's some idea about segmental metachronous adenoma rate. So what you find in the future in the segment might be reflective of what you had in the past. Okay, how you resect in the past. Now, in summary, right technique, right approach, assess quality, and one final pitch for the new frontier, I think, is we need to talk about overtreatment. Taking off diminutive polyps will be just a surrogate marker how well we find them and maybe how good we take them off. But most of them were never destined to transition to cancer. And that does not only affect the research that we use to make the risk for the patient, but also in the grander scheme, how we have a sustainability of our colonoscopy and polyp resection practice with respect to our environment. So with that, I close and open for questions. Thank you.
Thank you very much, Heiko. A very nice and short presentation. I have one question. You have emphasized the role of cold resection. Maybe we have to think now about when to use hot resection instead of when to use cold resection. Do you think hot resection should be only for very large polyps or pedunculated?
I think for pedunculated polyp, I think that should still be the choice. Just because the feeding blood vessel is bigger. And we can talk about electric artery settings, but this is going to get too far, I think. The resection, I think future studies have to understand the limitations of cold snare resection. It's very clear that cold snare resection is safer, but we don't know for what polyps it's also at least as effective as hot snare resection. So what was like the granular type, like this carpety large polyp, which is not a serrated one, is probably also very easily to resect with cold snare. It takes longer, but I would predict that's also maybe as effective as with hot snare resection. But this is just my personal impression. It's we need data on this, and we're actually in the process of randomized trials. So it will be a while until we have the results, though.
Heiko,
Yes.
you created this methodology of segmental metachronous neoplasia to understand the incompleteness of resection of the endoscopist. We are with WEO, and there are a lot of people who are responsible of organized screening program where you can have this data of metachronous recurrence. should we apply your methodology to our organized program to understand the rate of incomplete resection in our programs?
I think it's definitely worth a trial to come up with an easy analytic approach. It's not as easy, but the bottom line is if you have a segment where you removed a polyp before, if it's incompletely removed, this will show up in the same segment later. So that's like the bottom idea about this. And we need smart people like you, Cesare, who can come up with some kind of simple approach of an analysis, collecting the data per endoscopist, like 100 polypectomies or 100 procedures per colonoscopist in the last 3 to 5 years, and see what the follow-up was. It requires a follow-up of a patient, so there is some time situation involved.
There are quickly, Heiko, three questions in the same direction. Do you think cold snare resection is also okay for polyps with suspected high-grade dysplasia?
Well, personally, I think yes. The high-grade dysplasia issue is also a question of the definition and in terms of future risk. It depends a little bit on how the polyp is looking like. If you have high-grade dysplasia in the small one, I wouldn't hesitate. If it's like a large polyp that has other features of potentially invasive cancer, I would not. I would, approach that differently.
Thank you very much, Heiko, for this interesting presentation.